hear me, would you raise your hand, please? If you can hear me, tell the person next to you, please. Thank you. So my question was, if you can hear me, would you raise your hand? Good evening, everyone. Thank you. Some people do know me as Dr. Bradley, and I teach psych mental health nursing. And really particularly excited that we're having our guests here to speak this evening. Some of the students who are in Nursing 3117 have the privilege of going to the VA in Philadelphia. So some of this information will, I think, be really validating for you. And for others, it may be new information. And so we're really excited at the College of Nursing to have this event. It's co-sponsored by the Student Nurses of Pennsylvania. So you guys just finished your SNAP meeting, which is really great. And you got volunteers for tomorrow? So you're ready? For the McDaniel School, because they're going to go back to the McDaniel School. Joining Forces is an initiative. It's a national initiative. And the College of Nursing has joined in the Joining Forces initiative to really look at how we can help our veterans and their families. And tonight what we're going to do is we're going to have a lecture that deals with, it's a practice alert. It's to help our nursing students. Undergrads, where are you? Graduate students? Do you have any alums? You're both, right? Okay. Great. I said, any alums? Any alums who are here? So, you know, we were telling our guests that some of you are here, I didn't say under duress. I did say voluntarily, mandated for clinical. And we're really happy that you did that. I want to tell you there is a sign-in sheet as you're walking out that you guys could sign. It's up on the ledge there. So you can get credit for being here, because you'll wonder, did I get credit? I'm going to introduce our speakers, and what we're going to be doing is each speaker is going to come forth and give us some information, and for about 15 minutes. After that, we're going to have a panel discussion of question and answers where you guys can talk to our presenters about the information. It's really a pleasure to introduce to you Kathleen Pomorsky, and she's the Public Affairs Officer at the at the Coatesville VA Medical Center. She is going to introduce us to and give an overview of the Medical Center and the Department of Veteran Affairs. I will introduce the other speakers now, and as they come up, they'll repeat their names so you're aware of who they are. Kirk is the Director of Community and Congressional Affairs. He is a colonel in the U.S. Army who served 2 tours in Iraq and 1 tour in Africa. He is chief of the Special Functions Team and is a regular instructor at the North Atlantic Treaty Organization, also known as NATO, school in Germany, teaching operational planning and counterinsurgency operations. Additionally, he's employed full-time at the Coatesville VA Medical Center, where he's worked for the past 20 years. As the Director of Community and Congressional Affairs, Colonel Furnitz liaisons with community groups, elected officials, and veteran service organizations. He frequently attends outreach events aimed at enrolling veterans for the VA healthcare. This evening, he will talk to us about what it's like to experience combat and give us his firsthand experience. And we're really pleased that you're with us this evening. Our other speaker, Alan Ryland, the German pronunciation, as he told me, is a case manager for our newest veterans. Alan Ryland helps provide seamless transition service activities and the coordination of care and services for Operation Enduring Freedom, Operation Iraqi Freedom, and Operation New Dawn Service. These members and veterans are treated at the Coatesville VA Medical Center. The coordination includes efficient and appropriate delivery of care across episodes of care within the medical center, as well as community-based outpatient clinics, including mental health services. He is a veteran and has previously worked as a case manager with the elderly and those with traumatic brain injury. Mr. received his Bachelor of Science degree in social work from Widener and a master's degree in social work from Temple University. And so this evening what we're going to hear about is how the veterans get connected with the VA health system, as well as specific services that are available for recently returning vets. Our third speaker will be Dr. Robert Whitney. And Dr. Whitney is going to talk to us about PTSD, what it is, the symptoms, how it affects the family, and treatments. He is the program coordinator of the Residential Post-Traumatic Stress Disorder Treatment Unit, and he's worked in this program for over 20 years, assessing and treating combat PTSD in hundreds of veterans who have fought in wars such as World War II, Korea, Vietnam, Lebanon, Grenada, Panama, Persian Gulf. We could go on because we certainly have had those experiences of war. He has a degree, PhD in counseling psychology from Virginia Commonwealth University, and he's been, again, this program, the Post-Traumatic Stress Disorder Residential Treatment Unit, is one of the oldest and most effective in the country, and he will be talking to us about that. Welcome. And our final speaker, Lily Thomas. Lily Thomas began her social work career more than 20 years ago, so 20 is the marker for most of our speakers tonight, working with families in Chester and Delaware counties. And since May of 2010, she has been a suicide prevention coordinator at the Coatesville VA Medical Center. She assists veterans and active duty service members who are at risk for suicide. Her Bachelor of Science degree in social work earned from Westchester University, and her Master's of Social Work is from Bryn Mawr College Graduate School of Social Work and Social Research. So what we'll hear tonight from Lily Thomas is the reality of suicide and VA suicide prevention resources and efforts. And following that, we will have the panel discussion. So I'd like to welcome first to come up and to give us greetings and an introduction of the VA system, Ms. Kathleen Komorski.
Thank you very much. Thank you all for inviting us here today. We're very excited to be here. We're representing the Department of Veterans Affairs. And within the Department of Veterans Affairs, there is the Veterans Health Administration, which is where we're from. There is the Veterans Benefits Administration, which administers the benefits to veterans, and then the National Cemetery Administration. There are 152 VA medical centers and approximately 800 community-based outpatient clinics throughout the country. And VHA is the largest healthcare system in the country as well. Coatesville Veterans Affairs Medical Center is located about 40 miles west of here in Callan Township. And it's an integrated healthcare system dedicated to providing the best in care and services to our veterans. The hospital offers mental health care, primary care, geriatrics and extended care, specialty and women's health care, and pharmacy and social work services, among many other services, to veterans, both inpatients and outpatients. And it operates 2 community-based outpatient clinics in Springfield and Spring City, PA. And just to give you an idea of the volume of people that we see, during fiscal year 2012, the medical center treated 18,558 veterans, and 1,263 of those veterans were from the wars in Iraq and Afghanistan, and 871 of them were women veterans. So we're definitely gearing all of our treatment towards those specific populations, in addition to the populations we've been serving for a long time. We currently employ approximately 1,270 people, and there are 475 operating beds. And I'd just like to go over a couple of the highlights and things that we have going on over the past year or so. In May, our medical center was selected as one of 8 pilot sites nationwide to develop a team-based outpatient mental health care model. So the model being developed at Coatesville could eventually be used at all 152 VAs in the nation if it's the most successful out of all 8. So it's quite an honor to be selected for that. And additionally, 22 positions, mental health positions, were added through the mental health hiring initiative, which began taking place last May. So VA recognizes that there's a growing need for mental health care, and so there's been a big push to hire more professionals to take care of that. In February, VHA recognized Coatesville VA Medical Center's Patient Aligned Care Team initiative, which is a similar thing but in primary care. Currently, there's 15,093 veterans receiving their primary health care through this model. And we also have 10,466 veterans who are enrolled in My Healthy Vet, which is an online health management tool where veterans can check their lab results, check their appointments, and communicate securely with their provider. And then another initiative that we've had going on at the medical center since 2008 is the Departments of Housing and Urban Development, Housing and Urban Development and Veterans Affairs Supportive Housing Program, which is housing vouchers that veterans can use, veterans who are on the brink of homelessness or who have been homeless, to supplement what their rent payments would be. Our Secretary Shinseki, one of his main goals is to eliminate veteran homelessness by 2015, so this is one of the ways that we're trying to do that. Right now we're in the final design stages of a world-class outpatient space. The project will modernize an underutilized building into an urgent care, radiology, laboratory suite, and specialty clinics, including podiatry and optometry. And I don't know how many of you are familiar with our campus, but it began being built in 1930, so a lot of our buildings are older, and it's kind of like a college-style feel. But so there's a lot of updating that needs to be done. And then just to go over, and I know that Alan's going to talk about this a little bit, but our activities with the veterans who are newly returning, we've held 2 Department of Defense sponsored post-deployment health reassessment activities where veterans who are just coming back, their units come and they learn all about the VA healthcare, among other things, which Kirk actually was very involved in that. And then we also have a welcome home celebration every year, I think for the last 5 years, where we encourage people to come in, and the main goal of that being to get veterans enrolled for healthcare. And then later on this year, or actually next year, we'll be completing construction on a world-class hospice addition. And then another thing that we're doing that I would assume you're all kind of familiar with would be, we're on the journey to Magnet Excellence, and that began in January 2011, and that's the American Nurses Credentialing Center program that recognizes quality patient care, nursing excellence, and innovations in professional practice. And lastly, I'd just like to encourage all of you as you're graduating to look at VA as a potential career choice. It's definitely an honor to serve our nation's veterans, and we certainly offer a competitive salary, benefits, and all that good stuff. So thank you very much for having us, and I will turn it over to Kirk Furnitz now.
Well, hello, I'm Kirk Furnitz, and I have actually the pleasure of not only serving the nation as a soldier, but also serving our veterans at the VA. And I tell you, it is a pleasure to work at the VA, working with the veterans, and I can only caveat to what Kathleen just said, that it's a good place to start your career and potentially even end your career. And if you have any questions later on, we will be definitely happy to answer any of your questions. I used to be the staffing coordinator for nursing, and I certainly know who fell into my place and know her name and her telephone number, so it's a good choice and a good route to go. Before I go into, I have a few pictures here to lead you into a little bit of an experience that I've had over my 2 tours in Iraq. Some of it is pleasant, some of it is not. I left all the bad pictures, so don't worry about it. There's nothing unpleasant on there, really. But it gives you an idea. It will take you into my world for the next 15 or so minutes. And it will give you an idea why veterans, when they come back, are the way they are. And it will take some time for them to digress or take some therapy to get them back to some stabilization. We're there to stabilize them, but when we come back, it's kind of ironic. We have to be stabilized. Are there any veterans here by any chance? Okay, well, thank you, first of all, for your service, and I appreciate it. Have you been in Iraq or Afghanistan or anything?
Yes, sir, Iraq.
Iraq, where were you stationed at?
The first time I was a little bit, I was in the Ramadi area around 0506, the town called Habaniya. And then the second time, 0809, I believe, I was around Baghdad, around the Taji area.
Okay, Taji. Do you know where the Phoenix Academy is?
No, sir.
Right, it was right over in the Iraqi, because I actually had to stay with the Iraqis for quite some time, so it was next door, and the Phoenix Academy was where the Iraqis learn counterinsurgency operations. And I'll tell you, this has been one of the strangest wars we've probably ever been in, and I'll give you some insight about that here in a second. But to personalize it, I would like to just introduce my family here. This is my family, my wife and my 2 boys. And this actually was my last picture before I left. And, you know, that's where the stress begins. It begins really with the family. You know, my wife had the enormous stress of taking care of 2 boys, being really the single parent of a household and taking care of the rest of the, you know, whatever goes on at home, okay? And so we are here right next to the community club, so we had our last meal together, and it was sort of a strange thing. For the boys, this was their second time, so they knew that I was going to be departing here for a whole year. I knew I was going to depart for a whole year. This was my second time that I was leaving. So, you know, the first time I left, it was sort of an excitement. It was different. It was what I was, you know, I was trained. I figured, okay, now this is like the Super Bowl. I get to now figure out how good am I in this kind of environment. But the second time, you've been there, you've done that, and now you know that this is your, not even the first day of your 1 year, because that 1 year doesn't start until boots are on the ground. So that was kind of, you know, for me, it was a stress factor as well. So that's where the stress really begins, and this is what people have to deal with on the civilian side of the house, family members, of course, and also with the soldiers. But I want to let you know that war, no matter what war you're going to be talking about, maybe World War II or what this war here, is very complicated, and it is a very, and what people sometimes seem to forget is it's a very abnormal type environment, and you know, it's filled with a lot of stress. It's a very violent type environment, and it profoundly affects your entire spirit, your whole mind, and you know, physically and mentally, it affects you. Okay. Now, you're not going there just for 1 day or for 1 week. You know, this is not a hunting trip or anything like that. It is a 1-year deployment. So every day you live through this kind of unhealthy, abnormal type life. And if you look at your living conditions, let's just break it down. You look at your living conditions. Now, what are your living conditions? They're abnormal, okay? What are your working conditions like? Well, they're abnormal too. So there you got 2 factors already against you, and that's a good strike. The general atmosphere, what do you think that's like? It's very unhealthy, okay? And, you know, when you go to an environment like that, you won't really meet a whole lot of people who like you. And your freedom of movement is very limited. Your movement, so for instance, I cannot just go out and go to a restaurant. When you compare that to World War II, when soldiers got R&R and they were able to go back to Paris and have maybe a cup of coffee, or they were able to go to a restaurant, we didn't have that. We just couldn't go to Baghdad and just say, hey, let's just have a cup of coffee. It just wasn't, that was not even a part of our consideration. Your movement was contained within your military base. So if you consider Villanova as your military base, just imagine spending your time just in Villanova. And the only time that you spend outside of Villanova is to do your job, to engage certain SOIs, which we called spheres of influence. There was 2 SOIs, by the way, and that's why I'm saying spheres of influence. The other SOI was the Sons of Iraq. I don't know if you ever heard of that before, but I'm not even going to get into that. From the bottom of the ranks and to the top of the ranks, there is tremendous amount of stress placed upon you know, getting the job done right. Now, our culture is kind of strange. You don't know it, okay, but you will know it when you're over there. But our culture is very fast-paced. And I have a boss that will say, Kirk, I need this done, and I need this done, and I need this done, and oh, by the way, I need it done in 30 minutes. When you're in an environment like Iraq, you might as well take 30 minutes and multiply that to maybe days, 30 days. Nothing goes very fast. And so you have pressure from your folks, okay, that say, hey, we need to get this done, we need to get this done, we need to get this done. And now you have pressure over here that says, inshallah. Inshallah is a very famous word. You remember that word, inshallah? God willing, you know. And the way they said that, inshallah, meant a lot to me. When I speak to an Iraqi and he says inshallah, it means a lot to me how he says it. If he says inshallah, and it's stretching it out like that, it means it's not going to happen. Okay? So that's the kind of communication we had. Violence is always a factor and part of a soldier's life in a combat zone. And for us leaders, as higher as you go in a leadership position, may you be an NCO, an officer, now I'm a full colonel, but at that time I was a major, and then on my second tour I was a lieutenant colonel. The higher you go in the rank structure, the more you have to take care of your own troops. It's not just taking care of my own life. I got to take care of now 40, 50, 100 guys and make sure that they come home safely. And that's my job. That's a tremendous amount of stress. I have to make certain decisions every single day when we go down range. We call it outside of the wire. And outside of the wire would mean leaving Villanova and going downtown. Okay? Making that decision when I get from the intel report from the S2 coming to me and telling me, okay, Kirk, we just had an ID go off here, and we had an ID go off here, and we have a demonstration over here. Okay, got it. The mission is still on? Yes, the mission is still on. Well, I'm going to deviate my route. I never took the same route out, and I never took the same route back in. And potentially that might be one of the reasons why I'm still here. But those are some of the things that you have to think about. You know, my guys, initially, the very first time we went down there, they thought it was an adventurous thing. It's like, oh yeah, so, at that time, Major Furnitz, why don't we take that same route back? If they attack us, we'll attack them back. That was not the point. The point was stabilization for me, stabilization operations. And the less we fired, the better we were off. And the more friends I made, the better we were off. And that was a key thing. I'll give you a good example. The very first time I was going down range, which was early 2004, we're continuing up and going up to Tikrit. And we come through a small town called Adaluya. I don't know if you ever heard of that town. It's north of Balad. Adaluya. And my boss basically kicks me out of the Humvee and says, okay, this is your territory. I'm like, well, what do you mean? He says, well, this is where you're gonna be the mayor, so to speak, and do whatever you can, get everything started, and here are your 9 men. 9 men and myself in a town about the size of Lancaster County. That's a lot. And guess what? Here's the challenge. We are war fighters. We are trained to fight. We are trained to evade, to be killed, okay? This is the first time we are now acting out to be a mayor. None of us had any kind of experience of being in a role of being a mayor. Oh, by the way, I got a duffel bag of $13 million handed to me to manage that money as well. So that's how crude things have been, and that's what soldiers in my area had to deal with. And it's amazing how we carried this out. And it was challenges because we had to learn on the fly. We made errors, and that's why the war took so long. But we definitely did the best we could with what knowledge we had. So until that interim government came into place in July of 2004, between 2003 invasion till July of 2004, interim government, we were it. We were the government. And it was like we started making the decisions. But there were things that we had not expected, such as students coming to us. Are we still going to school? Faculty coming to us. Are we still teaching? Now, the faculty were all government employees, by the way, and the government ceased to exist. Saddam's regime was over with. The police was non-existent. We had people out of the retirement community coming up to us and saying, where's my retirement check? You're Americans, you're rich, you should have money. I didn't tell them about the $13 million I had behind me, okay? Because those $13 million were dedicated to projects such as building a clinic, renovating a hospital, maybe renovating a school, okay? Getting the police back up and running again. So those were some of the things that we had to do. The other interesting thing about our war compared to any other war is, and remember what I said, we are war fighters. We are trained to, to protect ourselves and to evade, to hide, to use camouflage and so forth and so on. But this time we were exposed. Me being a temporary mayor of a town, I can't be hiding behind a desk. I can't be low crawling through the buildings and stuff like that. I was exposed, and that was a very uncomfortable feeling because amongst the population, there was always a percentage that was an insurgency, and we had no clue who it was. It was very hard to distinguish from any of you guys who would be our enemy and who was not. So that was another stress factor. So another challenge that we face, obviously, is that soldiers learn to fight. They're taught to find their targets and so forth, but not knowing what the targets are. And that was a sheer frustration to many of the guys. Many of them that were seeking revenge when we were attacked. And I would say, be careful, because you got to be also mindful. The media is embedded with us 90% of the time. There's a huge population out there all the time. So you just can't go out there and just blazingly be John Wayne and start shooting around. And if you shoot one innocent person that was in the media, and guess who would get the flak? It would come right down through the leadership and then down to the lowest level of whoever pulled that trigger. So we were mostly exposed during times when we did project site visits. And I'll show you some of our projects, and hopefully you'll be amazed at what we're trying to accomplish, because there's more to this than just trying to hunt down the Al-Qaeda network portion. Okay? And I also conducted plenty of site visits and council meetings. So initially what I'm trying to tell you too is that the soldiers they had to relearn themselves. They had to learn how to become culturally savvy, so to speak, to be accepted over there. And they also had to become negotiators. I had to become a negotiator, and that was something new to me. Something totally foreign to us until we went into OAF and OAF. And by the way, Operation New Dawn now is over with, okay? Operation Iraqi Freedom is over with, but Operation Enduring Freedom is on and will stay on for quite a long time. We may remove ourselves from Afghanistan, but Operation Enduring Freedom will continue in Northern Africa, in the Horn of Africa region. So when these soldiers come back, really, after a prolonged time, you can imagine the stresses that they have. The animosity that they may have in having lost a buddy and living a day-to-day life that's really abnormal to them. That will, and I'm telling you, it's something that will never really go away, okay? If you have ever had a parent or somebody close to you pass away, you'll never forget that either, okay? This is embedded into your heart and soul, and it will stay there forever. The way you manage it is just, that's the key thing. How do you manage it? And everybody manages it in a much different way. Everybody has different capabilities and capacities and different stress levels that they can cope with. Okay, almost like a major car accident. God forbid that you ever be in one, but if you have ever been in a car accident before, some people will walk away, get themselves a new car, and they're back on the road again. Other people will say, I can't drive for a couple months, I'm going to have to cool off, and all this other stuff. And then other people, depending if somebody got killed in that car accident, may say, I'll never drive again. So we're all human. Everybody's a little bit different in those factors. But all these conditions, when you come back, get bottled up in a person. And it affects them very emotionally, okay? And that, you just don't lose that by immediately leaving a harsh environment. You pretty much, nowadays, with the technology that we have, you can be in Iraq today, and tomorrow you can be back at home. Just like that, okay? And in those situations, you cannot change from being this person today to being this person to tomorrow, okay? And that's something that our VA folks here have been helping us with tremendously to get over those kind of stresses. And soldiers are not very good about talking about their emotions. There's not a soldier that I know of that's very good to talk about, well, I'm kind of scared about this, or I felt bad about this and stuff like that. We are very, very poor in communicating our emotions. You may sometimes see it, but we're poor to communicate it. And on the other hand, you don't even get into discussions with your buddies, your other soldiers, about the experiences. Okay? Why? Because they have the same experiences. So why should I even talk to my buddy about the same stresses when he has the same stresses too? I'm not telling him anything new, and he's gonna probably tell me, you're barking up the wrong tree. Okay? So the only person to really to talk to would be sometimes the chaplain or, again, medical persons. But, you know, these things have changed over the time. Now they're encouraging more and more that we talk about our issues and our stresses. So let me go ahead and introduce you not only to my family, but to my life, the 2 tours that I've had. And there you go, there's my family. And do I see the, oh, I don't use this. I'm going to use the mouse. Yeah, I got it. So anyway, again, like I told you, this was my last day. This is at Fort Dix, New Jersey. And so your travel is your next stress level, okay? And there's a lot of waiting. You know, it takes 18 hours to really get there, but it takes 36 hours, basically, with the wait and everything else, and just all this running around, confusion. Finally, when you leave Kuwait is your first entry station. When you leave Kuwait, you end up in a C-130 like this one, and they pack you in there like a bunch of sardines, and you fly another 2.5 hours into really now the combat zone, okay? And that's why we're dressed up the way we are. Now we have to wear our helmets and put on our gear and all this other stuff. And this is my home. This was my first home. This was an Iraqi military installation at one time. And these barracks also served as bunkers for them at that time. There are no air conditioners in these bunkers. And they really didn't need them because they were like caves. They had it was interesting. They had a constant temperature of about maybe 50 or so degrees. But what you see is what you get. You know, our bathroom facilities are right there, okay? There was initially no PX. There was no laundry services. We had to do what we could do on our own. I used my washing machine was a cooler, and we used to wash our clothes in, and it was hard as a rock the very next day. But you wore it because you wanted to be clean, and it felt good to be clean. But that was our environment. This was our home for quite a while. This was my room, to give you an idea. And in the background, that was my area of operations, so I had that up. I actually slept with my enlisted guys in the same room. That's actually a no-no. Normally officers and enlisted guys are segregated, but as a team and as a special operations team, it doesn't matter. Rank really doesn't matter. And we all slept in the same room initially, and you see what turned out to be my closet is a bunch of PVC pipes, okay? We handcrafted, right here, we handcrafted sort of, you know, a nightstand. We had plastic furniture that we got accumulated in some areas. Our mail went over here, boxes and boxes, and if I got too much candy, I handed it out to kids, or my guys would eat it, you know, whatever. Our workstation is right over here, and you can see the computers right here. We had to log in, almost like a police officer. Every time you go out, you had to come back and log in what you have done and what was accomplished for that day, and what you are going to be accomplishing for the next 24 and 48 hours. That was our life. We worked pretty much 17 hours a day, every day. No holiday, no Sunday. Sunday, if there was a church service, you could go to the church service, or you could sleep in. Fridays is the Iraqi Sunday, okay, so they're off. So there were really no engagements with the Iraqis on a Friday. Sunday, our day that's supposed to be off, Sunday, was a work day because that's Iraqi work day. That's their Monday, okay? So Fridays was my day to get my equipment fixed, to get my equipment clean. And I was a huge stickler on my guys, making sure that, you know, I would let them sleep in, and I said, but by, you know, 3, 4, 5 o'clock in the evening, I want that Humvee up, and I want it ready, and I want it ready for tomorrow, and so forth and so on. And you can see we got fans at that time. Then eventually I moved into something like this, because the Army decided, okay, now we were getting these things in, we call them CHUs, container housing units, and they were coming in droves, one after the other, and then all of a sudden they would look at the rank structure and they would say, officers are getting these, and from that point on, I moved from this to eventually this, this. Anyway, this is my office, and I had a very savvy guy who was able to actually make these desks. And again, plastic furniture, you find them anywhere in Iraq. This is a Mosul, by the way, and the background satellite photos of the entire city of Mosul. Mosul has 2.1 million people in population, so that was huge. And we only had 1,600 troops on the ground to manage a city that big, okay? So that gives you an idea, you know, everything was priority, everything. And you will see all the everythings here in a few minutes. But Americans sat in the back, and sometimes I had Iraqi translators up in the front. So the green stickers right here on the computers that you see, that means they're secure, non-secure lines, and the red stickers means they're secure lines. And you can see we bagged up, our sandbags will bag up the window area and so forth and so on. But this is where we operated. This was where we kind of like played basketball. Every morning when we went out, and in the summertime, yes, it is hot in Iraq in the summer. In the winter, it's kind of nice. But in the summertime, it's already 102 degrees at 7 in the morning. And it just progressively goes up to about 138, 140. The hottest we ever had it was 148 degrees. And you wear all your, what we call battle rattle, your helmet, your gear, the whole thing. You wear that, okay? Yes, ma'am. Okay. So I just wanted to let you guys know that this is where we basically congregate. Some scenes of Iraq, just to let you know what the people lived through. Combat actions in Iraq caused a lot of damages. The banks never had any computers, by the way, okay? The banks had to pay people in cash, so that's where you see why you have so many people in line right here. A typical council meeting. I had 13 sheiks who were never really on the same page, so that was one of the main things. Working with the mayor, this is one of the mayors in Samarra, and we also worked with the mayor in Fallujah, trying to identify where the insurgencies were, getting with the community who would tell us where potentially insurgencies were if we treated them right, and then going after the insurgencies and also getting our cash, which was getting weapons and getting IEDs. And here's a typical ID, by the way. We worked with the government. Once the government was integrated into the system and they finally took control, we protected them. So on the left here, you see Iraqi soldiers starting to take over a little bit, and we're on the sideline helping out and kind of overseeing that they do the right job. The mayor of Mosul, engaging for the first time people in the population. They never did that in the old days, okay? It was a totalitarian type government. So this is new to them. They had to be taught to do these kind of things. And for him, this is a dangerous job because we lost several of those governors and mayors. People coming forth to talk to us. The police was a good ally. And one of the police officers that I worked with, this is his vehicle. During one of the engagements that we had, he was shot up pretty bad, and he ended up in the hospital. And when they ended up in the hospital, I had to go over there several times during the week to make sure that he was still alive. Because the insurgencies sometimes were embedded into the medical staff, and the medical staff would cut their throats. And I could come over there, and I would go in, and I would say, well, how's Hassad doing? Oh, Hassad passed away. Well, wait a minute, he only had a leg wound. Well, he passed away. And then I would investigate, find him, find his body, because they would lie quite frequently. And here you can see also in the hospital, the blood that was donated, that they never made it to the refrigeration. And this is 148 degrees outside, so you can imagine that this blood is no longer any good. This is what a typical hospital looked like, okay? Totally disshuffled, most of the time not because of the war, so to speak, but because they just didn't take care of their environment. There's no ownership, so to speak, over there. I provided a lot of fuel in Samarra and in Fallujah. When we went in back into combat actions over there, the electricity was completely out, so we provided fuel. And as you can see, we would escort fuel and get the hospitals continue to run. But this is what I typically would find outside of a hospital. So none of you nurses here or nursing students would ever want to see that, okay? This right here is also across the street from a school. And kids would come by and they would pick up these syringes and throw them at each other just for fun. Guess who's going to clean that up? We ended up having to get this cleaned up fairly quickly because we wanted to make sure that we took care of things. Trash was atrocious in Iraq. And one of the things that I would do is, you would see animals, obviously, feeding on the trash. But one of the things that I would do is I would start off at the basic level and get the kids, because it was easy to get the kids, and they always wanted $5, $10. It was easy to hand out from that $13 million I had. Hand out $10 or so to some of these kids and say, start cleaning this up. Once they did this, I would get adults to come and say, well, what about us? Initially nobody would come out of the woodwork, but the kids would. And we would start cleaning this up. And eventually when the adults came, we would get them uniforms. We would get them equipment. Some of the equipment is donated. Some of it is purchased. Okay? So the tractors would come from Europe, from Germany, from Turkey, from Great Britain, some of it even from Japan. And for instance, this garbage truck came from Turkey. But we had to be there all the time to manage these guys, to make sure that, number one, they worked. Because if we didn't, they would take off. And if they took off, they would give you the excuse like, well, I'm afraid of my life and I'm working for the Americans. Well, really, you're not working for the Americans. You're working for your own country, to stabilize your own country. But these guys, believe it or not, are targets. And so we had to protect them. A typical water treatment plant for the Iraqi version, and this is where they siphon off water from the Tigris. This is the Tigris, and it would go into a well like this. And then I ended up talking to a bunch of sheiks during one of our council meetings and conveying the message that we need to have a good treatment plant. And I can help you get that treatment plant. So we did that, and this is what ended up happening on the same site. Okay? So this is what we did. And those were some good news stories, and we always had the press out there when we completed those projects. Over here on the left, you see a school, the old school, and kids will actually go to that school. And on the right is a school that we funded. And again, where do the workers come from? We hired the workers. These are Iraqi workers. So at the same time, we took them out of the community to get them to work on their own projects. And they completed this school, and this is what the school looks like. This here is the worst story, really, in my deployment. This school, I went to visit to see if there was any renovation work to be done, and I was asked to come. I did not force myself over there. But once I left, it blew up. It killed several people, and to this day, I feel that it was my fault. But in return, we actually turned around, tore down the school, and built a new one, and that's the new school right now at the same site. We're getting Iraqi soldiers to work with the kids, to work with the community, because it was never really a good thing to see an Iraqi soldier in the old days. They would yell at kids and yell at people and all this other stuff, and now we're teaching the Iraqis to be a little bit more in tune to work with the kids and to tell them what not to touch out there, not to touch the syringes, not to touch any IEDs. This is my vehicle, by the way. It got hit by a suicide bomber, and it gives you an idea. You see the back. I was sitting in the front. The back is where my interpreter was, okay? And he was the target, actually. My interpreter was seen as somebody who was working against the Iraqi government and the old regime, okay? As a traitor, so to speak. And, yep, I'm done. I'm just closing out. So, just real quick. The bridge project, we cleaned that up. Christmas, and that's actually the last picture right there. So in conclusion, all I can tell you is, you see some of the stress factors that we have over there, and the VA is a great help. We have all kind of programs, all kind of services, from primary care to mental health, which PTSD is one, TBI, traumatic brain injury, and so forth and so on. So I hope this kind of gave you a little bit of an introduction of what the life is like and why the stresses are the way they are and why veterans come back and have issues for potentially a long time. Thank you.
Keep clicking on that X.
This is yours? This?
No.
Slideshow. You see the print graph? I have my glasses on.
Okay. Thank you. Good evening, and thank you again for inviting us here. It's a real honor and privilege to be able to talk to you about the veterans that we enjoy serving. And tonight I will be presenting information about the demographic and the statistical information pertaining to the medical and mental health treatment of our returning OEF, OIF, and OND veterans, Operation Enduring Freedom, Iraqi Freedom, and New Dawn. I'll also talk about the Postdeployment Clinic at the Coatesville Veterans Administration, which is a primary initial step for addressing these medical and mental health issues. The demographic and statistical information we'll look at is a cumulative report that encompasses a period of over 10 years, from 2002 until June 30th, 2012. Okay, and the information was gathered in ongoing quarterly reports which link information from the Department of Defense to the VA's electronic inpatient and outpatient system. And it addresses the utilization of VA health care and services by the, utilization of the VA healthcare services by the OEF, OIF, and OND veteran population. And the website where this information can be obtained is at the bottom. Okay. This, as I've said, the information pertains only to OEF, OIF, and OND veterans, okay? Who have access to care through the VA, okay? It is not a representative sample of OEF veterans who are eligible for VA care. And here are the numbers, okay? Of the more than 1,500,000 OEF, OIF veterans who have separated from the military service during the 10-year time frame, 55%, or about over 834,000, have obtained VA healthcare services since 2002. Of the 834,000, 56% are former active duty soldiers, and 54% serve in the Reserve and National Guard. 94% of those having sought services have been seen only on an outpatient basis. And only 6% have been hospitalized at least once since they're in the VA healthcare facility. Okay. This is a breakdown of OEF, OIF, and OND veterans by sex, age, branch of service, unit type, and rank. As you see, the U.S. Army has the highest percentage of those seeking services through the VA. But you can also see that some veterans, you usually think of, this time period is the highest in percentage, but yet you see some who are born prior to 1949. And so on. So it's not just those veterans in their 20s and 30s who are serving. This chart breaks down the various diagnoses of the OEF, OIF, and OND returning veterans. As you can see, there's a wide range of conditions that are reported. Of note are the three most common diagnoses of veterans were musculoskeletal issues, and that's the primary one, 57%. Next is mental health disorders. And lastly are signs of ill-defined conditions. These are things like undiagnosed rashes, sometimes generalized muscle aches, or intestinal upset. Sometimes those are things that are reported, but we just don't, we're not specific in saying exactly what the diagnosis is. So, and some of these things require ongoing evaluations, testing to find out exactly what is going on. Okay. This chart gives a breakdown of the OEF, OIF veterans diagnosed with mental health disorders. As you can see, diagnoses of post-traumatic stress disorder and depression head the list. But if you total the three categories of drug dependence, alcohol dependence, and also non-dependence abuse of drugs, add those together, it falls in about 118,000. So alcohol and drug abuse is significant too. And now, the percentage of VA healthcare utilization by recent OEF and OIF veterans may also be influenced by combat veterans. We have introduced an enhanced access to VA healthcare enrollment. In January 2008, this authority to receive services was extended to 5 years after their date of discharge. So anything that could be related to or cannot be clinically ruled out as being related to their military services, veterans can receive, OEF, OIF veterans can receive treatment for those services, as long as it cannot be ruled out. Now let's talk about the Coatesville VA and the OEF, OIF, and OND program. The primary mission of of the VA Medical Center at Coatesville is to provide seamless, quality health care services and benefits to our returning or OEF, OIF veterans. The program assists those who are injured or wounded in our combat military operations as they transition back to their loved ones. Our basic goal, or primary goal, is to ensure that returning veterans are aware of and can receive assistance in following up on services that are available to them, certainly services that they've earned, that they're entitled to, and this helps take alleviate some stress as to what's available, and so they have a point to go to and ask, what's available to me, how do I access things like education benefits. You know, you've probably heard about the GI Bill, and also things like sometimes veterans come back with financial issues that need to be addressed. So there are a number of things. A lot of times it depends on some issues with marital problems. So there are a lot of things that we offer that can be a benefit to the veterans coming back. So the goal of the OEF, OIF, and OND program is to assess every returning veteran for case management services. Case management services include, but are not limited to, assistance with obtaining appointments, applying for VA benefits. As I said, veterans are entitled to 5 years free VA medical care. After that time, only those things that are service-connected continue to receive ongoing free treatment. If a veteran receives becomes service-connected, then that diagnosis receives ongoing free treatment for the rest of their lives. Also, we provide information as far as access to community services, Social Security, some issues, finding employment, and so there are just a number of things that we work on, and we do use the community to help them. Service members and veterans include activated reservists, National Guard members, and as I mentioned, they're entitled to the 5 years free VA medical care. Okay? And the benefit covers treatment for medical problems potentially related to their military service. Now, if a veteran has a non-service related illness, they could incur a copay. Now, if they're out there playing football and somebody, they incur an injury, they could, have to, pay a copay for the services they receive at the VA. But there is no copay for costs for flu shots, pneumonia shots, EKGs, lab work, or x-rays. As far as dental care, eligible veterans can receive dental treatments as long as they set up an appointment with the dental office within 180 days after their date of discharge. Then anything that's identified in that dental evaluation can receive treatment and for it even after the 180 days. But the important thing is they need to be evaluated within that 180-day time frame. Now, the Postdeployment Clinic, which I had mentioned earlier, this opened in 2009 and provides comprehensive care to our newly returning veterans. It is located in the Outpatient Clinic, Outpatient Mental Health Clinic, and has a separate waiting area. Since its opening in 2009, the OEF-OIF Post-Deployment Clinic has served over 550 returning veterans at the Coatesville VA. These include initial assessments, evaluations by a primary care physician, mental health psychologist, and OEF-OIF caseworker, and doing initial assessments and following up on them. Treatment team consists of, as I said, screening veterans, evaluating for readjustment issues. What do you think are some of the primary issues that these veterans are going through? We already went through the list. Drug and alcohol can be a primary issue to be addressed. And we determine if case management is necessary. And as long as the veteran is willing to receive ongoing case management, we contact them on a regular basis, make sure question how they're doing, encourage them to follow up with appointments, making sure that they're doing what they can, and seeing how they're doing as far as following up with their goals, education, jobs, things like that. Since its inception back in 2009, what we do is we give a patient satisfaction survey to each veteran who comes through the clinic. These are just some of the responses that we have received as far as satisfaction. We have a very good success rate, and a lot of veterans prefer seeing 3 different disciplines at one time, and that way they can see everybody one time, not have to come back for multiple visits, and it's we get very positive feedback. Other outpatient services that are available, primary care, outpatient mental health counseling, military sexual trauma and treatment, sometimes homeless domiciliary, as has been mentioned. The goal is to end homelessness for the veteran population, and we are working at that. And so these are just some of the services that we provide, and we can also provide them, some of these services at the local community-based outpatient clinics located in Springfield or Spring City, Pennsylvania. We also have outreach events. It was already mentioned about the annual OEF, OIF, and OND Welcome Home celebration. We had that at the Strawberry Festival in Coatesville recently, or just this past summer. We have annual discussion groups. We are involved in the IRR, Inactive Ready Reserve musters for Marines that come back and are being debriefed. And we also have other things like veteran forums. So we're going out into the community and letting the veterans know of the availability. And a lot of times it's not just the veterans who come and ask the questions. A lot of times it's their wives or husbands, whatever, okay, coming and asking, can we have my father or husband or wife set up an appointment with you? So a lot of the times it's other family members who encourage this. Here is our contact information. Stacy Castell is our program manager, myself, and Shanae Miles are the case managers. And we do have a program support system too. Okay. Thank you.
At 200 to 250 admissions a year, we're way up there, actually probably number 2 in terms of how many guys we treat. We have 34 beds, and it's like in a dormitory setting, so it's not like a psychiatric ward where you're locked in. It's a voluntary program. Guys come from all over the place. We get guys from Boston and Maine and Washington and Virginia, and mostly in the Philadelphia, New Jersey area, but from all over the place. In fact, right now we're working on getting a guy over from an active duty. We work with the Army Warrior Transition Unit. We're getting a guy over from Landstuhl, Germany to come over to do our program. So, and that involves a little complications, as you could imagine. We treat combat PTSD. So, you can get PTSD from a whole bunch of things. You can get PTSD from rape. You can get PTSD from car accidents, or being mugged, or you can be an earthquake or a tsunami, So you can get PTSD from a whole bunch of things. But what we do in our program is just combat PTSD. We treat men and women veterans. We have a lot more men veterans than women veterans, but we take everybody as long as they have some kind of combat PTSD. And over the years, starting with Vietnam, we've treated nurses that were in the combat zone and treated, severely injured and wounded guys that had some troubles with that. So we've also taken care of all our wars and combat operations. So OIF and OEF, Iraq and Afghanistan, are just the latest in what we've been doing. And our program is pretty well rated. We've been either number 1 or number 2 in outcome effectiveness of all the programs 6 out of the last 7 years. So what's this number here? I just want to kind of give you an idea about kind of the size of what we're dealing with here. So 2 million, that's the number of service members that have been in Iraq and Afghanistan since September 11th, 2001. That's a lot of folks. But let's take a look at PTSD, because you don't get PTSD because you're in the military service, and you don't get PTSD because you're in a war zone. So there's some good studies, and I'll take a look. I'm going to change this a little bit because I just read a really good study out of Walter Reed Army Medical Center that was just published this summer that I read. So typically we think 15 to 20% of war zone veterans have PTSD, but the Army has the benefit in their research of determining what unit people served with in the war zone. So when they made a distinction between units with direct combat experience and units that were more support, they found that in the general population of people that were in country, it was about 6% had PTSD. But if you were in a direct combat unit, it was more like 13 to 20%. So somebody's got a calculator, what's like 20% of 2 million? 400,000. So is that right? Yeah, so that's a lot of people. So this is what we face in helping guys when they come back. Fortunately, they don't all come to our door at the same time, which is good. I want to point out a couple other things. One is that if 20% of the guys have PTSD on the top end, 80% don't. So when you're working with veterans, it doesn't mean everybody has PTSD. The other thing is if guys do have PTSD, it's treatable. PTSD is a treatable illness. So, and that's what we do. So I'll say another thing here. Being in the military, you're working with folks as nurses. They'll come in your clinics, over the coming years. Some of them will be veterans. It's good to ask if they're a veteran. So you kind of, it's a good thing to ask. Veterans aren't just people with PTSD that are victims that feel bad about, to feel sympathetic toward. I mean, veterans have strengths, and when you're in the military, you get all kinds of training and preparation. You work with people, you have good experiences, you can get leadership training. You work as a team to get something done. And you got to work with all kinds of people to get the thing done. You got to get along with them. So these are some of the strengths that veterans bring to their lives and wherever they go. And when you're working with a veteran in a medical setting in the future, also be thinking of this. But of course, today I'm talking about post-traumatic stress disorder. So, well, Colonel Furnitz didn't want to say the bad things. Since we're talking about post-traumatic stress disorder, it doesn't come from good things. Okay? So I'm going to cobble together some experiences that different veterans have had in different wars, and I want to illustrate what somebody may come up to us to get help with, okay? Rather than just talking about the symptoms. So let's say we have a guy, Jim, and he's over in Iraq, and he spends time in the evenings at his base with his buddies, and they lift weights together, and they do things together, and like men do, the way, of course, men show affection is they tease each other and insult each other and push each other around. So they get close to each other, and they're good buddies. So what the job is, you go outside the wire. So in this hypothetical case I'll give, so this guy and his buddy go outside on patrol. They have a foot patrol in the local area, and they're coming up to a marketplace, and it's just like any other day. It's like every other day. It's dangerous, but, something might happen, but it hasn't been happening. Suddenly, there's automatic weapons fire. This guy's maybe 10 yards from his buddy that he's his best friends with. He looks for the fire, looks at his buddy in this field of view. His buddy's been shot. So he's yelling and falling down, and everybody's returning fire, and he looks up, and there's an insurgent, and he's spraying, an AK at the American soldiers. And he's running away. And so this guy takes his weapon and shoots back to try to stop this guy because he's going to hit somebody else or he's going to kill him. And that's what you do. And this guy, he gets a few shots off, and the guy goes right beside a building and is gone. And some of the soldiers are going after him. Some of the soldiers are trying to take care of his buddy. And he's looking, and in the distance, his shots have gone beyond his focus of this guy doing the shooting and hit a woman, and she's laying on the ground. And there's the two kids that are crying over this woman. So you think about this. In less than 5 seconds, this guy's whole life has changed. Now, the next day, he's got to function. He can't go out there with the other guys and be distracted, thinking of his friend and feeling his sadness, feeling all the feelings he has about shooting this woman and the kids and what the effect of the family is. He's got to pull it together, because if he doesn't, one of his buddies is going to get killed or he's going to get killed. So he's got to find a way to take these intense emotions and put them somewhere that he can push back and still function and get through this, because people are relying on him. So that's what you got to do. So when we talk about PTSD, we're not talking about pleasant things. So we talk about a traumatic event, what I just described. Yeah, I think that fits. And what else? Response includes fear, helplessness, or horror. I guess that fits. So this guy goes through his tour, and he keeps it together, and he's functional, and now he's home, and he's really looking forward to coming home. But home's a different environment. Now suddenly you're safe, and you don't have to focus on this stuff every day. And now you're around a non-threat environment, it's hard to adjust to. When you're there, any moment, like Colonel Furniss was saying, all hell could break loose. You don't know who the bad guys are, and you're in danger. You come home, it's hard to get used to not being in danger. How do you turn that off? It's easier to turn it on than to turn it off. Let me talk a little bit about what we're seeing here. So, I've got some casualty figures. These are coalition figures, but 90% of them are Americans. And this is Iraq casualty, coalition casualties in Iraq. And you can see, when the initial invasion year in 2003, there's a pretty substantial number of people, but then it goes up for years, okay? Right to like where the surge is, and then eventually it drops by 2/3, then it drops by half, and half again, and finally in the last year there was 1 American killed in Iraq. When we started to see guys from Iraq, mostly Iraq, come into our program, what year do you think that was when we had more than maybe 1 at a time?
2005, 2006.
Huh?
2005, 2006.
Even later than that. 2007, we started to get people in the program. There's a delay. Guys come home, they're still in the service, then they get out, and they say, when I'm home, it's going to be okay. And they try to cope with whatever it is that they have brought home with them that they have to deal with. And some are successful and some are not. But when they're not being successful, that's when they seek treatment. Okay? And it's usually because of marital problems, work problems, drug and alcohol problems, legal problems. It's kind of like a crisis, as in mental health it usually is. A crisis brings somebody to get some help. But that, that's when we start seeing it. Now, I guess starting around 2010 or 2011, that's when 50% of the guys in our unit were from Afghanistan and Iraq. Now, there's like 65%. So we have this bimodal distribution, right? You have Vietnam veterans, and in the middle you have Persian Gulf War veterans and Grenada and Panama and the Beirut bombing. And then you have Iraq and Afghanistan vets. Okay, what to expect? Now, how is this going to play out? So it's hard to see these numbers, but it starts in 2001, and you can see there was kind of a low tempo, low intensity, and then it starts to go up and up and up till in 2010, the Afghanistan war is reaching its peak, and it's just starting to go down. So, given the delay with the Iraq war, what do you think we're going to be seeing over the next few years? I mean, when are we going to start seeing the number of guys coming in peaking? Maybe in another 5 years. Okay, so this is going to gradually increase where folks need help, and I do want to point out what Kirk said earlier. We're still in a war. It always surprises me. You look at the website news websites, and you look at TV news, you look at the radio and the newspapers. You wouldn't think so. Look at this. This is this year, and 90% of them are Americans. We're in a war, and it's easy to forget. You got to keep that in mind as we're going through this. All right, so let me talk a little bit about PTSD and the symptoms of PTSD. Intrusive recollections, that's something that when you've had a bad experience, you think about it, you daydream about it. The thing that makes an intrusive recollection different than a daydream is you can't stop thinking about it when you want to. Something reminds you of what happened, and then it comes to mind and you can't let it go. You eventually find a way to let it go, but it's a problem. It's intrusive. Nightmares. Well, nightmares are not usually all the time. You can get nightmares a couple times a week, perhaps, but it varies per the person. And sometimes they have no nightmares for a while, and then something comes up that reminds them, and a whole bunch of nightmares. Okay? Nightmares are irrational a lot of times. So somebody may have a nightmare. It's not going to be about the exact traumatic experience they had. They may be in Iraq and their family's there, and they're trying to save their family. Or they may be stuck somewhere, and it's Philadelphia, and then suddenly they're there and they need their weapon because they feel like people are going to kill them. So a lot of what happens in nightmares has an emotional truth to it. Okay, So you don't always have to have combat nightmares. Flashbacks occur sometimes, but you know, all the time I've worked with PTSD, you don't see people with flashbacks of any kind of duration. You know, flashbacks tend to last a couple seconds, because a flashback means you don't know where you are. Otherwise, it's an intrusive thought, or daydream. But if you really don't know where you are, that's a flashback. So unless you've been drinking or you're high, you're not going to see prolonged flashbacks. So the things you see in the movie about, you know, Vietnam veterans crawling around in their backyards, you know, with, you know, knives in their teeth, that's all like the movies and stuff. Psychological distress, that goes without saying. Avoidance is another big part of PTSD. Goes without, you don't have to think too hard about people avoiding their thoughts. They want to avoid thinking about their trauma, but they want to avoid their feelings. So what kind of feelings did this guy have and bring home with him that he may not feel comfortable with when he gets into something at home? Guilt? What else? What about his buddy? His buddy got killed. So he's got grief. So you're not going to see guilt and grief in the DSM-IV psychiatric diagnostic manual, but you will see it probably, I hope, and I've been lobbying for it in DSM-V. And you don't want to talk about these things. You know, if people are saying, you know, come home and people are asking you questions and they start to get in a lot of detail, and there's emotional stuff, you don't want to talk about that. It's just going to bring things up that it's the wrong place and the wrong time. It's not casual to you. It is casual maybe to the people that are asking. So when you're working with veterans that have PTSD, you don't want to be asking them deep questions about their trauma unless you're going to treat them. Okay? It's just not the time and place. Avoid activities, places, of people that remind them of what happened or of the war zone. Detachment or isolation. Detachment is like emotional numbing. If you have some really intense experiences, you feel kind of numb. You're not in touch with your feelings. Wives complain, you know, he never says he loves me, or, you know, he doesn't hug me, and like that. And you can't feel it inside yourself. Isolation's a little different, would be you want to be away from people. You might want to avoid people asking questions. You might want to be away from crowds, because crowds are unpredictable and make you feel unsafe. And restricted affect also goes with numbing. The third constellation of symptoms in PTSD are arousal symptoms. Sleep disturbance can happen. Guys are uptight and tense and nervous. They have trouble falling asleep. But a lot of times what we really see is people waking up in the middle of the night and not being able to get back to sleep easily. So, you know, if you have disrupted sleep a lot, you don't function very well, you know. It's like being in nursing school at final time, you know, you got to be studying, you know. And, you know, you think you're absorbing this stuff and you're like, you know, trying to drink all this coffee to make up for no sleep. You don't function well when you have sleep problems. Irritability or anger. So where does anger come from? I'll say a little bit about how this may manifest itself. So the guy we're talking about, there's three big things going on in that event. And there's more than that if you're in a whole tour. One is, people are trying to kill you and you never know when it's going to happen. So you have fear. And, you know, men don't like to talk about having fear. I'm not afraid of nothing, you know. So, but it's there. It's real. You don't even talk to each other about it. You know, but it's the real thing. So how do you overcome fear to do your job? You have to overcome fear to do your job. How did this guy go out on patrol the next day? What did he do? What do you do to get rid of that feeling? Well, one thing you can do is get angry. So if you get angry, that can overcome fear, and then you can do something and get it done. Okay? If you have to, like, shoot, because if you just get down behind cover, that's just going to lead to something bad. You know, the thing's not going to end. They're going to get closer, and you're really going to get it. So you have to, how do you overcome fear? You can get angry. All right? Another thing is he had grief. So how do you deal with grief? You get angry. Many times in groups, I've worked with guys, They're talking about one of their buddies who died, who was killed, and they go from talking about him and having sadness to getting angry at the government, or angry at their commanding officer, or angry at the people, the insurgents, or the enemy. The sadness and the feelings toward their buddy are gone. Well, that's what they have been doing. But when in treatment, you got to get them to stay with the sadness, because that's the only way they're going to get better. So anger is the infantryman's friend, I would say. Concentration, you can be distracted in all the emotional things that are going on and intrusive thoughts. Hypervigilance means you've been in a dangerous environment, it's hard to let go of that. You're uncomfortable, especially around crowds, where things are unpredictable and you can't see everybody. Exaggerated startle response, loud noises mean bad things. It's hard to just get rid of that. So what do we see in people that recently come from the war zone? You have all these symptoms, but what's different than these guys than a Vietnam veteran, which is like 30 years ago, maybe it's 40 now, right? So, 50. So a lot of hypervigilance. Exaggerated startle response. It's all those arousal symptoms, anxiety and panic attacks. If their job involved a lot of driving, some of them have a lot of trouble with driving because that means it's a dangerous situation. So they may overreact if somebody gets on their tail. And denial means like, I'll be all right, this will pass. And what people are telling me, is a lot of hooey. So let's talk about therapy a little bit. Actually, this is a picture from Djibouti, not Iraq. Somebody sent me. Therapy can have 3 different levels. One is the level of coping and support, where you learn coping skills, anger management, stress management, assertiveness, mindfulness meditation. You deal with here and now problems like marital and financial problems and job-related problems, where you can get really into it and do trauma focus, which is the most intense stuff we do. But if you truly have PTSD, you got to do that because it's going to keep lingering. Just go, the kind of therapies, individual, group, marriage counseling, medication. And I'd say it's very important coming home to find a new meaning in life, because you had a meaning when you were over there, and that was like really intense life, death, and situation, and people that you were very close to. And now that you're home, those people are not there. You got to find something to focus on, something that is meaningful to you, that you can kind of like readjust. That's what readjustment is about. So our main kinds of therapy we do, EMDR. Don't make me explain that, but it has to do with memories of the trauma while you're being distracted. And what it does is two things. One is it decreases the intensity of emotions, and it helps you think about it differently in a more healthy and growth-oriented way. Cognitive therapy, it's the same thing with more of a focus on thinking about what happened differently. So this guy's thinking, I shot this woman, I'm a monster, I did this, how could I do that? And he spends a lot of time trying to figure out how he couldn't have done it. How could he have done something different? That's all the guilt, and he's going through it in his mind over and over again. Kind of forgetting the context of this all took place in like 4 seconds, and they were trying to kill him, and his buddy's in terrible, dying over here. So you bring that back into it. So, all right, well, I'm going to move along here. I'll talk just a little bit about medication. You guys learn about medication. The main treatment for PTSD, according to the head guys in the field, is psychotherapy. Why? Because these are real things that happen. It's not an infection. It's not a traumatic insult to the body. So you have to reprocess what happened and make a different kind of sense of it. But we do use medication all the time. Like everybody on our ward has medication. The SSRIs, antidepressants, and venlafaxine we use a lot. We use mild stuff for sleep, trazodone and Ambien. And nightmares, prazosin, right? And quetiapine, which are very good for both sleep and nightmares. One thing you don't want to give guys with PTSD is benzodiazepines. You know, benzodiazepines, physician thinks anxiety disorder, PTSD, what's the treatment for anxiety, benzodiazepines. Once people start taking these, they really want to take them a lot and often, and it's hard to get them off. The other thing is they don't take care of the core symptoms of PTSD. They cause people to have less control over their emotions and their actions, and they can't feel their feelings, they can't benefit from psychotherapy. So this is very big, and they're addictive. They're very addictive. They're subtle, but they're addictive. So what Dr. Friedman said as far as prescribing benzodiazepines for PTSD, don't. Okay, I won't go into opiates because that's a whole other realm of epidemic. All right, and that's it. And Lily, there you go.
Oh, thank you. Hi, my name is Lily Thomas. I'm one of the suicide prevention coordinators at the Coatesville VA. I'm a social worker. Before I get started, I just want to say I hope people, if you leave in the middle, make sure you take the stuff we have out on the table. We have really nice stuff from the Coatesville VA. We have information. We have little bags with the crisis line on there. I brought a lot of stuff so everybody can have one and bring one to a friend. The crisis line is something we want out there. We want everyone to know that number. It's on everything. It's on the little bracelets that we give away, the little cards, everything. You can use, that number is something you can use for anyone. It's the VA partners with the National Crisis Line, and basically if anyone can call that number and get help. If you're a veteran or calling about a veteran, you just press 1 and they'll connect you to the nearest VA. So I just wanted to say that before, just in case people leave. I know we went over a little bit, so sorry about that. So basically, I'm going to talk to you a little bit about, I'll gloss over some of the stuff, like who are veterans, about the Department of Veterans Affairs, facts about suicide, myths and realities about suicide, and Operation SAVE, which is, I'll explain that, and available resources. So you'll have a general understanding the scope of suicide within the United States, know how to identify a veteran that might be at risk, and know what to do when you do identify a veteran, where to send them. So the federal definition of a veteran is any person that's honorably served on active duty in the armed forces in the United States. And the Veterans Affairs is Veteran Health Administration, Benefits Administration, and National Cemetery Administration. And what does the VA do for veterans? How do veterans know if they're eligible for care through the VA? You go to that website right there, and they'll give you all the information you need. And it's easy to make a referral, and you can sign someone up through that. So if you're with somebody in a hospital, and they tell you they're a veteran and they're interested in the services at the VA, you can help them do that. And we've done that a lot. Like I've talked to different hospitals all the time, and the person's not enrolled, and we'll do it online together, or I can sometimes do it over the phone if needed. But it's really important to help people to get signed up. And even if they don't want the services right then and there, you can help get them signed up, and then maybe down the road, that's something that would be appropriate for them. So I'll just give you some statistics before I go into the risk and protective factors. 36,909 U.S. deaths from suicide per year among the overall population. Suicide is the 10th leading cause of death in the United States. It used to be the 11th, it just went up. 16,799 U.S. deaths from homicide per year, so that's approximately half the number of suicides. And homicide is the 15th leading cause of death in the United States. There are some gender differences. Women attempt suicide 3 times more than men, and men complete at the rate of 4 times that of women. And usually with men, it's they use, men and especially veterans tend to use firearms or something more violent, whereas women tend to use means like pills, right? It's an estimated that close to 1 million people make a suicide attempt each year, and that's one attempt every 34 seconds. Scary, huh? There are some ethnic groups or races at higher risk, yes. I mean, of every 100,000 people in each of the following ethnic or racial groups below, the number died by suicide. This is in 2009. We're a little bit behind because the VA wants to make sure that their statistics are right, correct. I mean, we do a lot of research ourselves, so we're always updating that. The highest is white males, 21.6 per 100,000. Then Native Americans, non-white males, black males. The lowest rates are Hispanics and Asian and Pacific Islanders, which I actually didn't realize that until more recently. So 20% of U.S. deaths from suicide are veterans. That's a high number. Veterans are more likely than the general population to use firearms as a means of suicide, and that's one thing that the VA has. We give out gun locks to everyone, every veteran, every employee. We give as many as they want all the time. We want to make sure that if they have a firearm, they lock it up, they keep it safe. So one, there's not an accident, and two, having firearms, like some people will say, well, wow, if I have a gun lock, that's not, and I want to kill myself, you can still do it. Even if that gives that person a couple more minutes to go in, get the lock, unlock it, and take the gun, and that might prevent them from dying by suicide. So anything to prevent. I mean, we obviously advocate for people not to have firearms, but if they do have them in their home, we want them to use the locks and lock them up. So the VA is really pushing giving out those locks. 950 suicide attempts per month among veterans receive VA healthcare services. So again, we keep track of obviously people that are making attempts, people that are dying by suicide, and we're trying to eliminate as many risk factors as we can and give the people the services they need so they don't make an attempt or die by suicide. And I'll go into some of the things that the VA is doing. Decreased suicide rates in veterans aged 18 to 29 who use VA healthcare services. And 33% of recent veteran suicides have a history of previous attempts. So that's one thing that if you ever ask someone if they're having thoughts of wanting to hurt themselves, and if they say yes, even if they don't say yes, if they have a previous attempt, that's a significant risk factor. But I'll go into more risk factors. And some myth, is this a myth or reality? Asking about suicide may lead a person to take their own life. It is a myth. And people are really scared to ask that question because they're afraid to find what the answer is going to be. So if you ask that question, you need to ask it in a way that gives the person permission to say what they're really thinking. You don't want to say to someone, "You're not thinking of killing yourself, are you?" Because I know, but people do say it like that. You'd be surprised. People that you know better, they say it in a way like they are not ready to hear the answer. Or like, "Oh, you're not going to do that. You can't do that. You have a great life. You have kids. You have this. You can't do that." See, you want to give the person permission to say what they're really thinking. So it's important to ask the question in a way that you're going to accept what they have to say. Another myth, and I do hear this all the time, there are talkers and there are doers. And I know it sounds like, no, people wouldn't say that. Yes, people say that all the time. Most people who die by suicide have communicated some intent at some point. It's hindsight, obviously. Like after they die, the person says, "Oh my gosh, they did say to me this, this, and this." And this is something we always look at when someone dies. We look through the chart. We look through the notes. We try to figure out what went wrong and how can we do it better the next time. What did we miss? And we try to look at that. So, and that's something that most people have communicated something. So in other words, if we were able to help them through that crisis period, whatever it was that was getting in the way, we might have saved their life. So it's so important to pay attention when somebody says they're having the thoughts. Even if they say, well, I'm not going to do it, I feel this way. You have to take it seriously. And just having someone give their word isn't enough. So yeah, you need to take it serious. If somebody and another myth or reality, if someone wants to die by suicide, there's nothing you can do about it. There's a lot you can do about it. Most suicidal ideas are associated with treatable disorders. I mean, PTSD is one risk factor. It doesn't determine whether someone's going to make an attempt, but it is one of the many risk factors. Bipolar disorder or different mood disorders is one of the many risk factors. Homelessness, one of the many risk factors. There's a lot of them out there. There's a lot we can do about all those things. So if somebody's in a real crisis, they need help through that. And you want to be honest with the person and say, like, listen, this is awful what you're going through, but there are things that we can do. Let's figure this out together. And that's where you come in and say, I'm going to refer you to where you need to go. And the more resources you have as a nurse, as a doctor, as whatever profession you're going into, the better. You want to be able to refer to the appropriate places. The VA. That's why you need to ask people when you're working with them, are you a veteran? And it's so important to ask that. And they might say, yeah, and I'm connected with the VA, I just choose not to go there. That's fine. But they might say, yeah, I don't really know much about it. And you could say, oh, okay, well, why don't we find out about it? So, another myth or reality, he or she won't die by suicide because they made plans for vacation, they have young children at home, they made a promise to you, and you know how much they love their family. Unfortunately, the intent to die can override all that. And in the moment, when they feel in the crisis and they feel that hopeless, and they feel like they're not going to get the treatment they need, they're not going to get the help they need, that overrides everything. So again, it's really important that you take it really seriously. And, we all, obviously, you going into nursing, you care about people. I'm a social worker, psychologist. We're all in this because we care and we want to do something to help people. And it can be overwhelming to us when somebody says, yeah, I think about taking my life every day. I'm not going to do it, but yeah, I think about it every day. It's overwhelming. I know it is for me when I hear it. And I think, oh my gosh, like, are they going to be okay when they walk out this door? And I hope, but I think that we have to do more than just hope. We have to make sure that they're getting everything they need. We're doing the right kinds of assessments, and we're referring people to where they need to go. Because if we don't, we're not going to be able to reach who we need to reach. And this all leads us to Operation SAVE, another acronym. Signs of suicidal thinking: ask the important question, validate the veteran's experience, and encourage treatment and expedite help. So the importance of identifying warning signs. Many people don't show warning signs. They don't show the signs of intent until after, obviously later, after you look back and you think, but we kind of gloss over them. And a lot of the behaviors may be signs, a lot of the behaviors that they're having could be signs that the person needs help. And veterans in crisis may show behaviors that indicate a risk of harming themselves. Sometimes people won't say that they're suicidal, but their behavior is very different. Like, riding a motorcycle after they had, a 12-pack of beer without a helmet. Obviously, that's saying they don't have very much regard for their life. Or playing Russian roulette. I've heard that before. And they're saying they're not suicidal. They're not considering that a suicide attempt, but they pulled the trigger of a loaded gun and held to their head. So obviously, if someone says things like that, even if they're saying they're not suicidal, you have to look at the behavior. You have to look at everything. And some of the warning signs that are more obvious, but even hopelessness, feeling like there's no way out. Like some people will say, no, I'm not suicidal, but they also will say that, I'll ask someone, do you feel like you can get yourself out of this? Do you feel like if we give you the treatment you need, or if we get you the appointments you need, that you're gonna be okay? And when people say no, I can't imagine myself being okay, that's like really significant, because hopelessness is huge when it comes to predicting if someone is going to make an attempt or not. The problem is hopelessness is kind of vague. Like, what if I say, are you hopeless? And they say no, but then they describe hopelessness. So it's like you really have to do some talking with someone to see where they're at with that. And anxiety, agitation, sleeplessness, mood swings, all these things are things that add to it. Like if you're not getting any sleep and you're agitated all the time, and what Dr. Whitney described as PTSD, some of those symptoms, it's hard to take it, not sleeping day after day. And then you start abusing maybe drugs or alcohol to try to help with some of the symptoms, because you're not getting the help that you actually need. And there's some rage and anger and risky activities. And so these are all kind of what someone might look like without saying. And also very obvious is when they're saying they want to hurt or kill themselves. And looking for ways to die. Sometimes people they have their medications, we know they have their medications because they fill them, and then they want more. And they're not in a good place, and they want more, and that they've made attempts prior with trying to OD. So I always say, well, why do you need all these meds, extra meds for? Well, I need them because, they're always looking for ways to get more medications. Some people actually hoard pills in case they want to kill themselves later. So they're planning ahead. So you could ask that question, like if you know that somebody is thinking about things like that, and you know that they might have extra pills, you're working with somebody, and I don't know what, if you're out at a home, if you're nursing in the community, and that people have, people keep extra pills. I mean, extra medications. I know I sometimes do, but sometimes I now knowing what I know, I throw them out because I just don't want them in the house. Because sometimes, one, they expire, and two, it's just not a good idea to have extra medications around if you don't need them. So, there's things to think about. That's ways of making the environment safe. You want to take away means. Just like you want to give somebody a gun lock. You don't want them to have extra pills, things like that. So we're always looking for that. There's also self-destructive behavior with drugs and alcohol and other weapons. Some veteran-specific risks: frequent deployments, deployments in hostile environments, exposure to extreme stress, physical, sexual assault while in the service. And again, it's not limited to women. Some people think that is, and it's not. Length of deployments, service-related injuries. There's a lot of people that if they come home and they can't do the job they did before because of a service-related injury, and they have some other issues going on, it just makes it that much harder. So could you imagine your whole life has changed, and then on top of it you can't work the way you did before, and you have other issues, so you're always thinking about how this person is doing. So we want to reduce the environmental risk. And before I get to that, I just want to say about some risk and protective factors. Some other, we looked at like warning signs, but there are a lot of risk factors. And I mentioned a few, obviously, PTSD, frequent deployments, also like homelessness. Homelessness is a big issue. If you have nowhere to go at night, all the other issues are exacerbated. It makes everything that much worse when you don't have anywhere to go. So that increases your risk of making an attempt. It increases your risk of feeling that hopeless feeling. So that's why we're always looking at as much as we can. We're not looking at the person in one way. We're trying to see them kind of in a whole light. Like this is a full person. They have a lot of things about them that they might need in their life. So just because they say, yeah, I'm okay at the moment, You know, you want to look at where this person goes home at night. Who's their support system? What do they have? Who's going to help them if they start to feel suicidal? And that's what we do. We do safety planning, and it can, if it's used, it can be a great tool to help someone when they're in distress. It helps them identify what their warning signs are, what they look like when they're not in a good place. And then it helps them to identify things that they can do internally, externally, what friends to call. And you can even write down the phone numbers and say, you know, like, oh, okay, working out is really helpful for my mood. Well, then work out, go swimming, join the health club. Like you want to kind of focus on some positive things. And to help and remind them to do that. And that's why you can write it down so they could look at it. You'd be surprised if someone uses the plan. I had someone once call me, and they were on a bridge, and they were on the way to the bridge, and they were thinking about jumping, and they were trying to do everything on the list, and my name was on there, so they called me. That was a good thing. I mean, I'm not kidding. That really happened. So. And you want to reduce environmental risk. You want to reduce the risks in the community or in your environment. If you're in a hospital setting, if you're in the home working with people, and we just talk about some inpatient suicides. And hanging is the most common method for an inpatient suicide. And a lot of people think, okay, you want to eliminate high structures. No. You could actually die by suicide from something this low, right here, this knob handle. You can't have that in an inpatient psych unit. So if you know someone is suicidal and you're in the emergency room, you want to make sure that you clear the area of as many things as you can. And here's the kind of the breakdown of that. And if I should go faster, let me know. So like I said, inpatient, the psych units are the highest where people make attempts and complete. So again, eliminate structures that can support a weight. That could be clothing rods, curtains, the sprinkler heads. Ours are all breakaway. And we do, it's another thing, the VA does rounds. We do them in every patient area, and we do them regularly and make sure. And every time we try to make changes, we try to improve it, we try to make it a little bit better than the last time, because we don't want people making attempts, and we certainly don't want them dying by suicide. Include even towel bars, toilet sinks, everything. Drapery cords, shoelaces, things like that. You know, so if you're with someone who is suicidal, you need to make sure that they don't. You want to eliminate as much as you can until you can get them in a safe environment where they're, one-to-one. Reduce access, and that's the first thing we do when people come in. We want to make sure they don't have any kind of objects to hurt themselves. We want to make sure you take away if they have medications on them, if they have anything. You want to furniture, breakable furniture, anything, razors, anything. And all of our windows, obviously, they don't open all the way. Which is frustrating in the summer because it's nice out and I want to open it, but it only opens up like that. So, but it's important, again, that if you're working with people and you're in that kind of setting, that you are aware of that. Even if you're not in the psych unit and you're working in an ER or something, or you're on the med floor, and you know that somebody has had suicidal thoughts, they have that background, they're not doing so well. You want to be aware of that. You don't want to just hope like, oh, well, they're in the hospital, they're going to be okay. You don't know that. So that brings us to ask the most important question of all. Are you thinking of killing yourself? You don't ask it when you're walking away. We kind of talked about that. You want to ask it in a way that you're okay with hearing the answer. And you don't want, not in a no answer, not in a way that you want to hear a no answer, like you're not thinking of killing yourself. You remain calm. You want to listen more than you speak. If someone tells you they're suicidal, you want to listen to what they have to say. And you don't want to argue, no, you don't want to do that. And I know that sounds silly, but people do that all the time. They argue, not argue, but it's like, no, you don't want to do that. You have so much to live for. You got to be positive. It feels like that's the right thing to do because you want them so bad to feel good. You're just like, come on, you can do this. But the bottom line is this is the way they feel. And you need to respect that. And you need to help to let them know that it's okay to feel that way. You're gonna get them to where they need to go for help. So you want to have that open body language. You don't, and it's hard to do because, like I said, it's scary when someone says they're thinking about killing us. So the first thing you do is, oh my gosh, like just stay right here. Let's put you away. Let's lock you up because I don't want, I can't handle this because it's hard. So again, you want to be open and willing and not passing judgment. Like you can't do that. It's against your religion. They're not thinking rationally. If someone is seriously considering this, they're not going to think in those terms. They're going to think of what they want to do to get away from the pain that they're feeling. And you never want to keep it a secret. If someone tells you, I don't want anyone to know, it's not a big deal, I thought about taking pills last night, I had the bottom of my bed, but I didn't do it, please don't say anything. You cannot keep a secret like that. That is something that you have to let the person know this is really serious and you're concerned. No, it doesn't mean that you have to, involuntarily commit them in the psych unit, but you need to communicate this to another provider so they can help this person. And that person might be irritated with you in the moment, but you might save their life if you do it. So it's important to do it. You will hear, somebody will ask you that, I'm sure, at some point in your career. I've been asked that question many times. Don't say anything, don't record it. No one needs to know. People do need to know. And you're there to say, reassure that you can get help. Help is available. You don't want to lie. It's not easy to get help, but you can say to the person, listen, this is a really difficult situation. There is help out there. I will help you find what you need. I'll make the referrals that you need. I'll see to it that you get to the person that you need to get to. And then you're on your road. Then you're on your way. It's not easy. I'm not saying it's easy. You never want to make it easy, and you never want to lie to someone because you need, you want them to trust in healthcare. And of course, if someone has a gun, never negotiate with someone who has a gun. You need to call the police. If they have a gun, you need to call the police. If they have took pills, cut themselves or anything, hurt themselves in any way, you need to call 911, you need to get the security, you need to get the police. And remember, when a veteran at risk for suicide leaves your facility, you always want to give them that number, 1-800-273-8255. It's everywhere, that number. And actually, I'd give that number to everyone and anyone. I always say, it's a great number to have. If you're on Wyoming on vacation and something happens and you need to get to the nearest VA, they'll get you there, and they will. I had a guy drive across country to another VA. He was going to VA in California, and he was in a car accident. He used the number, and he stopped. It was, I think, somewhere in Kansas City. They helped him. He actually totaled his car, but they helped him get to his destination. So he used that number, and it will help you. So, and you could use that number if you're not sure what to do in the moment, and you could use that number, and they will help you get to whatever services you need. And here's some websites, and I have lots of information. Please take a bag, fill it up with all kinds of stuff. I don't care how much you take. The more you take, the less I carry home. And information about all the different services that we have. And that's not something we're going to do. So I tried to go quickly because I didn't want to go too far over. I don't know, should I open it up for questions for everyone? Or?
Well, I just wanted to say we just want to thank our speakers for validating a lot of what we have been doing with the psych mental health nursing course. And it's really appreciative for us to hear how that works with the vets and works with at the Coatesville VA.
because I think we don't always know where will we make the referral, who would we talk to about that. We're going to take that number and put it in our bag, and you're going to take the bag. I really want to particularly thank our speakers for being here and for offering us the information that you did. The second thing I want to do is to give you a round of applause for being here since 8:30 for class. They're going to be available up front for a little while if people have questions for them, but for the rest of you, we're going to say goodbye. Thank you.
Thank you. Team stuff.